Sir, it's sharp 5. So with all your due permission, can we begin with the session?
Sure. We can begin.
Good evening, everyone. This is Batul from IGCP, and I would like to welcome all the viewers who have joined our platform for the better exchange of knowledge that is going to be shared by our keynote speaker, doctor, for today's session. Sir needs no introduction, but it's my pleasure and honor to introduce him at our platform. He is none other than a very renowned cardiologist, Dr. Keshavamurthy CB, sir. Sir is MD in General Medicine, DM in Cardiology, DNB in Cardiology, and consultant at Manipal Hospital, Mysore. With the help of Sir, we'll be taking a close look on today's topic on this occasion, which is World Hypertension Day. And the topic for today's session is Hypertension Awareness and Importance of Treating to Target. Before moving on to today's session, let us have a brief look on what the topic says. Hypertension or high blood pressure is a common condition that affects millions of people worldwide. It is a major risk factor for cardiovascular disease, including heart attack, stroke, and heart failure. Despite its prevalence, hypertension often goes undiagnosed and untreated, leading to serious complications. So on this occasion of World Hypertension Day, with the help of Sir's wonderful inputs, we'll be learning more about the topic and its complications associated with HTN to overcome barriers and to provide effective treatment. Now, without any further delay, I would like to welcome Sir at our forum and would like to hand over the session to him for his precious talk to begin. Sir, over to you.
Thank you so much for the kind introduction and thanks for the opportunity to speak to all of you today on the occasion of World Hypertension Day 2023. May 17th every year is celebrated as World Hypertension Day, basically to create awareness amongst the population, the general population, as well as the physicians. So that by increased awareness, we tend to kind of notice this disease better, try to get more information about this disease and how we treat this. So the theme for 2023 is measure your blood pressure, control it to targets, and therefore thereby live longer. That is the theme of this year's World Hypertension Day. As part of the World Hypertension Day, I would give you a small information. We just conducted a blood pressure awareness campaign in our hospital and screened about 125 staff members for hypertension. You will be surprised to know that about 10% of this population, this pool of people, which includes all security, housekeeping, nurses, doctors, about 10% had borderline high blood pressures or high blood pressures, and about 3 of them required immediate attention. That means that blood pressure was above 160 by 110. And this is the kind of incidence of this disease in what we think as a healthy population inside a hospital. So what should it be in the general population? That is left to your guesses. So wish you all a World Anti-Hypertension or a Hypertension Awareness Day, so that you all become aware of your own blood pressure, of your near and dear ones. And if you're practicing, you take better care of your patients after listening to this exchange of ideas. By spending this time, I hope we will learn together walk this journey of hypertension awareness and why it is important to treat to target. Only if we are aware it is not enough, we have to treat them. And when we treat them, we have to get down the blood pressure reading really to the target levels. Otherwise, the benefit is lost. And there's no point in diagnosing and partially treating them, half-heartedly doing something. So we have to treat them to target. That is the emphasis. So the key messages from this talk is hypertension is known as the silent killer. Many of you know that hypertensive patients rarely complain of any symptoms, and many of the patients, when we prescribe them drugs, they are reluctant to take them because it is a silent disease. They have no symptoms. Why should I take this drug? How will it make it better? What will it prevent? These are all the questions running in the patient's mind. And several times after taking medication for a few days, they drop off because they don't have any symptom improvement and there are no symptoms to improve. So they drop it off. So at the beginning itself, you should take time to convince the patient, make them understand that it is a disease process. It is not just a high reading which you can ignore. It can lead to devastating complications like mentioned earlier, heart attacks, strokes, and most importantly, heart failure. In a quiz, I asked the question, what is the most important cause of heart failure? Many doctors replied that it is a heart attack, but it is not, it is hypertension, because hypertension is a very common disease. It is a major contributor to heart attacks and stroke and heart failure. Not only that, it is easily treatable. Now there are more than 100 kind of molecules available for treatment of hypertension. If you have adverse effects with one drug, or you have any other issue with one particular molecule, you can always go to another molecule. So that is a kind of wide availability of medicines that is there. The next point is the low awareness in the population. Of course, population can be excused for not knowing about that blood pressure, but physicians cannot be. Even the physicians are not aware. Patient was tense, patient was anxious, he has not slept well yesterday, or he has taken a high salt diet. So many excuses we create in our mind and prevent appropriate treatment. And one thing we have to convince ourselves today is that treatment to target definitely reduces mortality. It is not an innocent disease, and it is not a fight about numbers. It is about treatment to target and reducing the mortality and morbidity due to this condition. So that is the message I want to convey to you today. The rest of the talk is all about a few more information about hypertension, but that is the key message. And if you have taken it, this talk has been successful. Many a times we tell the patient that lifestyle is the most important thing, but how many of them do really take this oath to follow a good lifestyle? Hardly about 10%. Compliance to dietary restrictions, compliance to quitting smoking, compliance to restriction in alcohol intake, and change in stress levels. All these are very, very, very low in the general population. The compliance over a period of time, people don't stick to their lifestyle changes. They're used to that conditioned lifestyle which keeps them happy, and they continue in that. For example, alcohol, it is a major recreational kind of product in our country. So once they have a high blood pressure reading, many patients in the acute state, they stop it. But once the acute phase is over, blood pressure is controlled with medicine, they return back to alcohol. This is the kind of low adherence that we see in the population. So how will we diagnose? Just 2-3 important points about diagnosing. We cannot randomly take pressures and say that you have high blood pressure. There are different methods given by the WHO, given by several organizations worldwide, the Joint National Committee on Hypertension. They have definite guidelines on how to measure blood pressure. Patient should be positioned in a chair, feet should be uncrossed under the arm should be at heart level, otherwise you will get erroneous readings. Measurement should be obtained after 5 minutes of quiet sitting. Patient should not be talking, caffeine, smoking 30 minutes prior. Average of 2 measurements should be taken because one reading can be erroneously high, and greater than 2 elevated measurements in 2 separate visits for over a 1 week or more, you should diagnose them as hypertension. Patient should sit quietly and should his arm should be without any movements. If there are movements, patient is fidgety, moving forward and backward, or talking, or anxious or agitated, obviously there will be erroneous reading. In many of the clinical trials, there are to eliminate the human errors. Patients have been put into a room where there is no human being. There is only the BP apparatus which is connected to the patient. Patient sits there quietly for about 10 minutes without any human intervention. The BP instrument automatically takes 2 or 3 readings, whatever number of readings you have set, and gives an average of that reading. That seems to be more reliable. Of course, there are newer methods. There are several monitoring devices. There is ambulatory blood pressure, which seems to have a very important role, especially with the newer guidelines. There is more emphasis on home readings when the office readings are high, so that when patient is ambulant and in his natural settings, what BP you get seems to be more reliable and reflective of what events that the patient can have in the future. So there are several things about clinic readings. Some patients have what is called as white coat hypertension. Whenever they go to a doctor, they feel anxious about a diagnosis or the hospital environment itself and have high readings. But that also has a value. If patient comes into the hospital and has a high reading and says, I have normal readings always at home, it still is a different reading than the general population. So you should be careful about this population and monitor them closely and for some time in the future. I mentioned about home monitoring. There are several continuous monitoring devices. With the advent of technology, there are several wearable devices which can be worn on the wrist, which can be worn on the arm, which continuously measure the blood pressures at whatever set intervals and give you a comprehensive reading. And of course, as physicians, we always use 24-hour ambulatory BP monitoring, especially in the initial diagnosis. Sometimes when a clinic reading is high or two readings are high, patient is doubtful about the diagnosis. You put this 24 hours, let the patient go home, be in his natural environment, work, do whatever he wants to do every day, and then come back in 24 hours and see all the readings. We get a very good idea of how the patient's blood pressure is behaving, the biological clock, the biorhythm, what happens to the early morning surge, whether the patient is dipping his blood pressures normally at night. All these important information is obtained from 24-hour ambulatory BP monitoring. And when patient is on medication, to see the degree of control, and when patient's readings are fluctuating too much, a very useful tool to control their blood pressures. Random high readings and visit high fluctuations of blood pressure also seems to carry a higher mortality. Suppose you see a patient who comes to hospital every month to visit the doctor, and his one reading is 120/80 normal. Next reading he comes with 170/90. The third reading he comes with 140/90. There is a wide fluctuation in readings. It has been shown that those patients also seem to have higher morbidity and mortality and events connected to hypertension. These are some of the statistics which are easily available on the internet, and you can look up. About 1/3 of adults worldwide have high blood pressure. Very, very high number for any particular disease. 30% of the world population will have hypertension depending on the age group. 46% of the world's highest rate of high blood pressure are in sub-Saharan Africa, despite the nourishment levels. 2/3 developing countries have high blood pressures. 1.5 billion adults across the world. Look at how big the pool of hypertension patients will be. And one of the most common conditions leading to heart disease, stroke, and heart failure, as we said. And CDC, Communicable Diseases Control, calls it the silent killer. It leads to stroke, heart attack, coronary artery disease, and heart failure. And I'll talk briefly about awareness in the next slide. Number one contributing factor for global health, major risk factor for cardiovascular disease. It causes 9.4 million deaths worldwide. Big disease. And total number of hypertensive Filipinos is now more than 12 million. This from Philippines. So this is the Indian scenario. Again, awareness, treatment, control. These are the three important words which we have to see. We'll briefly discuss that. What is awareness? What is the treatment that we prescribe, and how many of them are actually controlled? This is the region-wise distribution, showing that green to red about awareness, treatment, and control. So there is what is called as the 50% rule for the mostly for developed countries. About 50% of the people are aware of their high blood pressure. That is, they know that their BP readings have been high due to some readings being taken at some point in their clinic visit or a random check. They have found that. And out of that 50%, only 50% will take the treatment, take the actual treatment, because others will think, okay, I'll modify my lifestyle and recheck again in 3 months and things like that. And they keep on excusing themselves from taking appropriate treatment. Many of the patients are misled by their physicians, sometimes saying that only 1 or 2 readings were high, other readings are normal or borderline, so you can be on lifestyle, and never follow them up, which is a big mistake. And when they come with an event, then only we realize that this patient could have been treated better and this event could have been prevented. And out of this, only about 50% are treated to target. But in India, it is dismal. It's very, very dismal. In some of the studies, the awareness and treatment to target is as low as 17%. So that is, of the diagnosed patients, only about 17% were taking actual treatment and they were controlled to target levels, which is very, very dismal. These are the two numbers to remember. There are several guidelines across the world, the Indian hypertension guidelines, the Joint National Committee, the European guidelines, WHO. There are so many guidelines, so it all confuses because of the large volume of data available about hypertension. But you remember only two figures. You have to remember only two figures. For diagnosis, use 140/90. For treatment to target, use 130/80. All the other confusions result from various trial data. Like I said, some of the trial data show that lowering the blood pressure to very what we think as very low levels, like 110/70 or 120/80, which is the ideal blood pressure, improves the morbidity and mortality events. There were some trials to support that. That's why the confusion. And the various comorbidities. For example, in renal patients and in cardiac patients, it is clearly there is enough data to show that lower the blood pressure, these patients should have a revised target. That's why there is a lot of confusion of which picture to follow. Should it be 150/90 for people aged above the age of 65 years, like in the European guidelines? So it all tends to confuse you. So just remember two figures, 140/90 and treatment to target at 130/80. So key messages in treatment is extremely important. Some people, even physicians, have the idea that with age the blood pressure rises. In an elderly patient, let us leave it at around 160, 170, things like that. In an asymptomatic patient, we should never leave the blood pressures beyond target. We should always attempt to treat these patients to target and get them under good control to give them the maximum mortality and morbidity benefits. So that is extremely important thing to follow. It is life-saving. We should convince ourselves that treatment of hypertension is life-saving and it is essential to prevent a vascular event. If one family member, one loved one has an event like a stroke, then you will realize that how preventable it was by just giving him a simple blood pressure tablet. So always the first step in therapy is non-pharmacological. Patients also like this, and this is what is recommended in worldwide across all guidelines. We say that the first step should be non-pharmacological therapy. If there is no strong family history of hypertension and you detect them in the first stage, if it is not like blood pressures are not in the stage 2 or stage 3 or a hypertensive emergency, when you exclude these patients, the other patients who have a clinic reading which is higher than normal should have these for 3 to 6 months of doing lifestyle modifications, reducing the salt in their diet, regular exercise, modifying their stress and other habits, moderation or stoppage of alcohol, complete quitting of smoking, and control of various other comorbidities will help them to reduce their blood pressure. Weight reduction, with particular attention to reducing central obesity, has been found to reduce the blood pressure levels and may be curative in some cases. If patients take their advice seriously and reduce their weight and change their lifestyle, many of the patients in stage 1 hypertension return to normal levels and continue to enjoy a healthy lifestyle without drugs for several months to years. So there are some common excuses which I mentioned earlier for accepting high readings. Sometimes patient says, I forgot to take medication today. That's why BP reading is high. And then you say, okay, take your medicine and come back, and patient never comes back. I'm fine with current level of BP. This is a very common excuse. Let it be 140, 150. Let me accept it because I'm fine. I don't have any symptoms. But it is the silent killer. The undercurrents are not felt by the patient. The pill burden. Commonly, we burden them with many pills. For example, in severe hypertension or in resistant hypertension, patient may be taking up to 5 medications, which may be causing side effects. The cost, the number of pills itself, the patients get fed up taking it over a long period of time, because hypertension is a lifelong disease. They have to continue to take it. There's no limit. You cannot say, okay, take it for a month and then stop it. So ultimately patients get fed up. So all these factors have to be taken into account. Patients sometimes blame a single diet of high salt. Yesterday I had some pickles, or day before yesterday I visited a wedding where I had high salty food. All these are excuses given by the patients. I did not sleep well. My home readings are always normal. Then you ask them in particular, have you recorded it? There is no record of that. So I tell every patient who says home readings are normal to keep a blood pressure diary and show that diary compulsorily. If they show that diary, then I'm convinced. Otherwise, when did you take your last reading? I'm monitoring. That's what the patients say. But when did you take your last reading? That would be 6 months or 9 months or sometimes 1 year or sometimes never. But patients tend to give all these kind of excuses, which you should look through quite easy to look through when you carefully examine and address those concerns. Sometimes pill burden is an important concern. If you have a family member with hypertension, you'll realize what all it takes to maintain a regular schedule of medication for that particular patient, especially elderly who cannot read the print on the medicines, who cannot read the milligram on the tablet thing, and somebody has to put their tablets into a pill box and give it to them. So all these are practical things which as physicians we should address. There are, of course, genuine concerns like adverse effects of medication, especially pedal edema, which for physicians we say it is of nuisance value, it's of no value to us. But for a patient, he cannot wear his chappals, he cannot walk, he cannot wear his new shoes. So those are important concerns, and we have to address them very carefully without kind of brushing them away. Cost of medication, especially in India, many times we see that the cost of medication, it adds up to more than the monthly income of the patient. How will that patient buy the medicines? And that is when we move into the economics of treatment of hypertension and give the appropriate therapy for that particular patient. On the physician side, there are several excuses. Readings are reasonable. What we think of as reasonable may not be reasonable according to the guidelines. And for that particular patient, he may have underlying chronic kidney disease, which you are trying to prevent. He may have heart failure and heart disease, coronary artery disease, where you want lower levels of blood pressure. So never say it is okay for that BP reading. Always look at reducing it to guidelines. We have topped off doses of medication. Sometimes we are given 2 or 3 drugs and gone to the highest doses. Still the blood pressure is not under control. Then you have to really look at what is causing this, what is causing the resistant hypertension, is there compliance issues and things like that, and then adjust the medication appropriately. Elderly patient, there is a common belief, like I said, that BP readings increase with age, so we'll accept higher readings. The earlier dictum was 100 plus age should be the systolic BP. So we used to accept readings like 180 in elderly, but later on we found that this is also incorrect. Elderly also have morbidity and mortality and stroke risk due to high systolic blood pressures, and appropriate control is most important. Only in patients who have very fluctuating blood pressures, who are symptomatic when we lower their blood pressure to than what we are used to, there we have a genuine excuse. Suppose there is a very elderly gentleman with recurrent falls and his blood pressure is 170. And when you lower the blood pressure to say 140, he tends to have dizziness, generalized weakness, he doesn't have enough cardiac output. Those are the patients who are excluded from this. But otherwise, you should always look at treating to target. Patient is a stress personality, so will not treat them. Clinic readings are always high, his readings are at home or always normal. So these are the kind of excuses that the physicians commonly give, which should be taken care of. There are other important things. Like I said, therapy is lifelong. Therefore, keep an eye on the cost, pill burden, and acceptability to the patient. We cannot brush away the patient concerns. Sometimes we say, no, that is a minor adverse effect. You take it. The good effects are much more and things like that. But you should sit in the patient's chair and see what is troubling the patient. Sometimes patient is not able to express that the cost is high compared to his salary. So you should sit in his position, carefully look at things, counsel him that it is an extremely important thing to take this medicine. Take time to counsel the patient about the importance of BP control, especially since it is a silent killer. Use home monitoring devices liberally. Nowadays, we tell almost every patient, because the blood pressure monitoring has become automatic and the device has become very cheap and easily available at every corner medical store. So we tell most of the hypertensive patients, take a blood pressure monitoring device, monitor it at least once a week or once in 2 weeks. If patient is very stable on medical management once in a month, even that would be fine. The other important thing from the physician side is that combination therapy is required in nearly 2/3 of patients. Earlier dictum was give one drug, slowly increase it to maximum dose in about giving a minimum gap of 2 weeks for the drug to act, go up to the maximum dose, then add a second drug. But no more so, because we realize that many of the patients require, for good target to therapy, they require a combination. And upfront, if you start a combination, you can reduce the number of adverse effects, because both the drugs will be in a moderate dose. They will not be at the top dose. So the adverse effect profile will be better. And combination will reduce the pill burden. Patient gets used to taking a combination pill thinking that it is a single pill and thereby get better blood pressure readings. Choose a drug with adverse effect profile like placebo. Since patient has to take lifelong, you have to choose drugs which do not produce any change in patient's daily life. Like for example, telmisartan and bisoprolol, these are my most preferred drugs, because when you give these drugs, you don't have edema, you don't have postural symptoms. With bisoprolol, very good control of heart rate, good control of blood pressure. Especially this combination, I found it very useful and very close to the definition of an ideal drug. They are true once daily, so that the pill burden is also less. When you combine these drugs and give a single tablet, about 50 to 60% of the patients have good control in 2 to 3 weeks. The other messages are, be always aware of comorbidities, kidney disease, diabetes, heart disease, especially, or stroke. Patient has postural symptoms. All these have to come into play when you look at a patient and adjust his medication. Treat the dyslipidemia, treat the diabetes. Only then you will get a composite good endpoints. If you ignore the comorbidities, treat only the hypertension, it will not be good. If you treat only the comorbidities, ignore the hypertension, then it is equally bad. So look at the patient as a whole, look at all his comorbidities and try to give the appropriate therapy for a patient. For example, patient has chronic kidney disease. We cannot take ACE inhibitors or ARBs unless he goes on dialysis. So those patients require to be managed with calcium channel blockers, beta blockers, and other groups of drugs, centrally acting agents. So that way you have to individualize the therapy till you get the patient to target. So the classical approach we all knew from the textbooks from the time we were studying that A, B, C, D, or in a particular order, you go with a diuretic or a beta blocker or a calcium channel blocker, then step care therapy. It was called a step care. Increase it step by step and all that. Now, in the modern era, that is all gone. There is no more step care therapy. You look at the patient's comorbidities, whether the patient has diabetes, you are trying to prevent kidney disease, then choose the most appropriate drug or the most appropriate combination of drugs and start it up front. There is no need to wait for the step care. Drug choice based on individual therapy and based on the comorbidities. So there are, like I said, there are various classes of drugs, ARBs and beta blockers and calcium channel blockers and diuretics, which you can choose to use according to the patient status and the patient comorbidity, age, what type of personality and all that. Also consider when patient has resistant hypertension and blood pressure is not coming under control, then you have to sit back, refer the patient to a cardiologist, refer the patient to maybe a hospital setting to see what is really happening to this patient, whether it is renal artery stenosis, aorta arteritis, chronic kidney disease, secondary hypertension, Cushing syndrome, pheochromocytoma, missed coarctation of the aorta. We have seen this in a few cases. Obstructive sleep apnea is extremely common. It's a very, very common disease in the general population, especially the obese people, which causes refractory hypertension. Whatever drugs you keep on piling it, the blood pressure will not be controlled unless you treat this, diagnose it and treat it appropriately. Another few words about resistant hypertension. If you have more than 5 drugs and still readings are above target, there could be other factors like drug and diet compliance, conflicts in therapy. Patient may be taking NSAIDs for joint pains or steroids for asthma. That's why BP is not coming under control. Stress and lifestyle changes is extremely important. In a stressed patient, whatever amount of drugs you give, his blood pressure readings, random readings could be high. Change of medication or combination suddenly confuses the patient. Patient drops one of the drugs. Patient reverts to his earlier medication, which he was most comfortable. Thereby, you get a pseudo-resistant hypertension. And of course, ambulatory BP monitoring will give you a clear picture whether it is truly resistant hypertension or just patient is doing something with respect to his compliance. So this is one new therapy that has come. I just wanted to mention it for a minute. Renal denervation is now available in India. Extremely expensive though, but in the future the expense might come down. For resistant hypertension, we take them into the cath lab and using radio frequency energy, we ablate the sympathetic nerves of the renal artery circumferentially using a catheter-based model, which reduces BP and about 97% procedural success. Currently costs about 7 lakhs or something, which is ridiculous for treatment of hypertension because they can get a lifetime of drugs with that amount. But I'm sure the cost will come down as we use it more and more. So World Hypertension Day message is that we should create awareness by public health education. We should spread the message of benefits of therapy. Stick to guidelines, whether you are a patient or the doctor treating a group of patients. Always stick to the guidelines because that has been shown to improve patient outcomes. Diagnose early, treat appropriately. Always monitor the patients. That is the most important thing. Thank you all. Thank you all for your patient hearing, and I hope I have got a few messages across so that you can pick it up in the future and in your practice.
Thank you so much, sir. Thank you for the wonderful inputs that you have shared upon the topic.
Yeah.
We have received few questions, sir. So with all your permission, I would like to put it across to you.
Definitely.
Yeah. The first question is, what causes hypertensive emergency in patients with no history of chronic essential hypertension?
Right. Patients who come with hypertensive emergencies may be of few categories. One is patients have never been diagnosed. They just come, they are present with a hypertensive emergency. That is one category of patients. The second category is secondary hypertension. Those who have secondary hypertension, like I mentioned in the causes, though they can present acute kidney injury, acute renal failure. They can have first onset hypertension, which may be very high. So these are some of the categories: the secondary hypertension, undiagnosed essential hypertension, or a diagnosed hypertensive patient who has done something. He has dropped off his medication, or he has taken some contraindicated medication and came with hypertensive emergency. So these are the few things that I can think of.
Thank you so much, sir, for answering this question. We'll move to the next question that we have received. And the question is, how does patient education affect hypertension treatment outcomes?
Absolutely. As I started stressing from the first slide itself, patient information, patient education is extremely important. If the patient doesn't understand the importance of taking antihypertensive drugs, he will not take it because it is a silent disease. Unlike angina, in angina, a patient has chest pain, it bothers him a lot, and you give drugs, he feels better, so he'll continue to take medication. In a symptomatic disease, always the improvement of the symptoms motivates the patient. In a disease like hypertension, where it is a silent killer, there is no motivation for the patient to take medication. So you have to really take time to educate, use the help of a counselor, use the help of his primary physician to convince him to take medication. Extremely important. Otherwise, patient will drop off.
Thank you so much, sir, for answering this question. The next question that we have received is palpitation of peripheral pulses necessary in patients with hypertension?
Absolutely necessary. Absolutely necessary. Otherwise, you miss diagnosis of coarctation, iodoarthritis, some of the diseases, what is called as pulseless disease. All these diseases will be easily missed. Like in any patient which you see, you have to examine the peripheral pulses. As a cardiologist or as a physician, it cannot be underscored. You have to examine all the peripheral pulses, and if you find something missing, there should be an obvious cause. Sometimes dorsal speed is maybe absent in some patients congenitally. So if there is a cause or a record of that missing, then it's okay. Otherwise, you have to investigate what is the cause of that and treat the patient appropriately.
Thank you so much, sir, for answering this question. The next question and the last question for today's session is, what is non-dipping in nocturnal blood pressure?
Yeah, normally when we go to sleep, the systolic blood pressure drops by about 20 and the diastolic blood pressure by about 10. This is the normal dipping pattern when we get into sleep. So that always the night blood pressures are lower than the day blood pressures. So if they do not dip by this percentage, if the cutoff is about 9%, at least it should dip during sleep. If it does not dip, these patients are called as or termed as non-dippers, and they are at a higher risk of events. Finally, we know that blood pressure is a measure of our vascular health. Our arteries should contract and relax also. So if they have lost that function due to atherosclerosis, it is an indirect measure that the vascular health is poor. So non-dippers tend to have higher incidence of stroke and other cardiovascular events. So dipping is a very important phenomenon.
Thank you so much, sir, for answering all the questions and for sharing such wonderful inputs upon the topic that you have pondered today. So thank you so much for that. At the outset, I would like to thank all the viewers who have joined our platform and who were there with us throughout the session. And with all the last comments, sir, we can conclude the session here for today.
Sure. Thank you for the opportunity, and thanks to all the participants for your time. And I hope that message is carried across and you will be able to treat your patients and give them better outcomes.
Thank you so much, sir. Thank you. With this, we are concluding the session here for today.